simplify things a bit, and we're going to talk about seizure rescue medications. So I'm Dan Freedman. I'm one of the epileptologists here at Dell Med. And, oh, that's not showing up. There we go. I have no conflicts of interest to disclose relevant to this topic, but I will be talking about off-label usage a little bit. I think it's hard to talk about seizure rescue medications without discussing that. We're going to briefly review the history of seizure medications or rescue medications, I should say. Any good talk starts with some history, right? So I'm going to bore you a little bit, and then we'll hopefully get into the meat of it. So this tablet is at the British Museum. It's a 6th century Babylonian tablet. Supposedly describes the first incidence of status epilepticus. Has anyone seen this before? No. Cool. Good. You get to learn something. So it says that the epilepsy demon will come and touch somebody, and then they fall down and have a seizure. So this is the falling sickness. It says that if the demon visits you 7 times in one day, so 7 seizures in one day, you die. And so this is the first description of acute repetitive seizures. These are some old treatments for seizure rescue medications. The picture on the left is amyl nitrates. So those were used in the 1870s as a kind of a smelling salt, and it caused vasodilation, just like we use for heart problems still today. And some people thought it helped seizures. That continued into the 1940s. So people were still using this in the 20th century, which is crazy. And then bromides, of course, everybody knows bromides, the original seizure medication, first used as a rescue medication. So Sir Charles Locock, who was the obstetrician to Queen Victoria, so not a neurologist, he first gave this medicine to women with catamenial epilepsy. Interestingly, some of those women had hysteria, so they didn't even have epilepsy. So I had to figure out a way to get PNES into this talk, right? So, so the first use of a rescue medication was for people without epilepsy, which is really interesting. So what is a rescue medication? We want this medicine to be as needed. It should be used easy to use by non-healthcare personnel. It's an acute treatment for repetitive seizures or worsening seizure activity above someone's baseline seizure activity. And then we use it to treat a variety of things. So we use it to treat status epilepticus, but that's not what it's actually indicated for. And so that's why we're going to talk about the off-label usage. We also use it for clusters of seizures, so acute repetitive seizures, febrile seizures, and catamenial epilepsy. Also for illness-provoked seizures, right? So if somebody's sick, we give them a bridge of medicine while they're sick. So what different routes of administration do we have? We have intranasal, buccal, sublingual, rectal, and enteral. And some of those are FDA approved and some of those are not, and we'll go into that some more. So we want to use a seizure rescue medication 5 minutes in a seizure, right? So that's kind of the idea of preventing status epilepticus or treating early status epilepticus. Technically, that's not part of the FDA labeling, but I think the idea of designing a randomized controlled trial where we deny children treatment to status epilepticus medication doesn't really make a lot of sense. It wouldn't pass any IRB, right? So that's why we have this acute repetitive seizure labeling. So what is an acute repetitive seizure? Nobody really has a clear established diagnosis of that. So the wording of the FDA is worsening of seizures above someone's baseline. Sometimes we think of that as 3 or more in 1 hour. Sometimes we think of that as 3 or more in a day. It really depends on the patient. Febrile seizures, obviously with clustered or prolonged seizures, that would also be a reason to use a rescue medication, but again, not explicitly part of the labeling. And then catamenial epilepsy is something where we see that kind of cyclical increase in seizures with the menstrual cycle, and another opportunity to use rescue medications. The ideal rescue medicine is quick-acting, easy to use, safe, effective. You want a small volume, so that's another thing. Where I initially trained, we did a lot of what you might call bootleg intranasal midazolam. So it was intravenous midazolam that we drew up into a syringe, and then we gave an atomizing device. And if you put too much pressure on that plunger, it actually just creates a jet of stuff. It doesn't properly atomize. And so when you think about a parent in a stressful situation, they're probably not going to give that very effectively, right? And so, I mean, as a resident, I tried to give it, and I couldn't give it effectively. So it takes some training to actually get that right with a slow rate of force on that plunger to get the atomization. And it's a pretty large volume too. So we actually did it to each other as residents. And so you get all this stuff coming out of your nose afterwards. It's pretty gross. And so you want a really small volume of stuff that's actually going to get absorbed rapidly. You want a rapid onset, you want a long duration, and you want to treat multiple seizure types ideally. So intranasal is a very, very effective way to do this. It's a highly vascular mucosa. It absorbs the substance very well. You get a rapid onset, so 1 to 5 minutes for time of action. You avoid first pass metabolism, which is great. And it's relatively easy to use, and you don't have to take somebody's pants down, right? So rectal administration is really not ideal for older patients. And so it's a major, major factor when we're thinking about medication for our patients. Rectal also rapidly absorbed, a little bit longer though, it's important to note. There's a bit more variability in the absorption too, so something that's interesting in the FDA labeling of diazepam. So if you compare intranasal diazepam to rectal diazepam, there's better absorption, or sorry, more consistent bioavailability from intranasal than rectal. Why that is, I don't fully understand, but it is just interesting. And then for a long time, the only FDA-approved medication was, of course, rectal diazepam, right? So that's the one that a lot of daycares are more familiar with. So in recent years, we've had to do more education about intranasal routes, but we still face the same challenges that you have social embarrassment. For kids that have spasticity or mobility needs, it's pretty hard to administer. So what are some other routes that may be explored in the future? None of these are FDA approved. Really, none of them really exist in the United States currently, for the most part, but there are buccal, sublingual, enteral, and inhaled routes that are being explored. I think one thing that could be really cool in the future would be a dissolvable film. So we have that for clobazam, right? So what if we did that for a rescue medication? If someone does that, send me a check, please, because I came up with the idea. So, and then in other countries, they have a thickened gel formulation. And so I had a patient come from another country, and they showed up with their rescue medication from somewhere in Europe, I can't remember where. And it was this mucosal gel. It was really interesting. So something that doesn't exist in this country, we had to switch them over to a medication in the United States, but it was a cool thing nonetheless. Again, we want that rapid absorption, which you can get from the oral mucosa, just like you could from the nasal mucosa, but unfortunately, we don't have a FDA-approved medication at this time. There is also the risk of aspiration, which, that's why we want a small volume. You don't want to be putting a large amount of liquid in somebody's mouth while they're seizing. You also don't want to risk injury to the caregiver. So this is the problem with tablets and things that go into the mouth, is if you have to insert your fingers into the patient's mouth, you could get bitten during the seizure. And then if someone's tonic during a seizure, it may be hard to actually get something into their mouth too. So rectal diazepam has been around since 1997, which is pretty crazy to think about. I still occasionally find schools or daycares that don't want to give rectal diazepam. And so it is interesting to me that that's not, even though it's been around for a long time, it's still not necessarily standard in some places. The data is really impressive. So we can see that there's a significant decrease in seizure-free intervals after 12 hours after giving the medication. So this can help prevent kids from going to the ER potentially, or seeking, or ending up. We can't say that it necessarily prevents status epilepticus, but you can extrapolate that if you're stopping acute repetitive seizures, and those acute repetitive seizures have a high risk of going on to status, we're hopefully intervening early enough, at least that's our theory, to prevent that. The absorption is very fast, so within about 3 to 7 minutes after administration, and it can remain kind of within the system for up to 9 hours. So we see some sustained effects. There are some adverse effects with respiratory depression, very rare though. So we know from all the studies that have been done with rectal diazepam and other benzodiazepines that the risk of respiratory depression is far greater from continued seizure than from the medication itself. This is the dosing. I think we're all familiar with it, so I'm going to skip over it. What I do recommend though is people have like badge buddies or print it out like at your computer station. It's just way easier than having to look it up each time. Intranasal diazepam or Valtoco is the brand name. So we have to discuss brand names because currently those are the only available formulation of that medication at this time. So intranasal diazepam was approved in January 2020 for patients greater than or equal to 6 years of age. It has comparable bioavailability to IV diazepam, a very rapid onset of action. It has some adverse effects, pretty mild, so you get some irritation of the nasal mucosa, far less than what they used to experience with the kind of bootleg version, because that was an intravenous formulation of the medication that was given nasally. This is more designed for absorption in the nasal mucosa. Respiratory depression was not reported in the trials, so what they did is they compared intranasal diazepam to rectal diazepam, and that's how they got their FDA approval. It is contraindicated in neonates and infants because there's this thing called gasping syndrome. It's not actually related to the benzo, it's related to the alcohol preservative used in the medication. And it's also interesting to note that the FDA approval is for the medication as part of this device, right? They are one and the same. You can't use it, you can't extrapolate from the FDA approval to use the off-label intranasal midazolam that was injectable. This is the dosing for that. The reason the dosing is important is when we talk about nasalam, we have to talk about the fact that there is not weight-based dosing to nasalam. So nasalam was approved in 2019 for patients 12 years and older. It is equally as effective to IV diazepam. It has an onset of action about 10 minutes from the arrival time of the ER, so very rapid as well. It was able to show that they could shorten seizure time, and then the half-life is relatively short compared to these other medicines that we're talking about, so you have less risk of drug accumulation with repeated doses. Both nasalam and Valtoco have in their labeling that you can give repeated doses, so you could do that with either medication, but less risk of the drug accumulation with this one, in theory. With intranasal midazolam, there's also some risk of nasal discomfort, rhinorrhea, the standard things that you would expect for something that, since we're putting something into the nose. You're also going to get sleepy. It's a benzodiazepine. You're going to get sleepy from all these. Dose is not weight-based, which is really, really important. The Epilepsy Foundation has really awesome education on seizure rescue medications.
Anyone can be trained.
Sorry. I don't want to actually watch the video, but it exists, and and I think it's important for everybody to know about, because this is how we can get everybody educated on seizure rescue medications and seizure action plans and seizure safety information. So if you're not seizure first aid trained, I highly recommend going to the Epilepsy Foundation and getting that done. It's an online course. It takes 90 minutes to do, and it's free, which is great. So the last one that we have to talk about is oral clonazepam. This is the trickiest one to discuss because it is FDA approved for seizures, but not for the acute repetitive treatment of seizures. And so, but it is commonly used. I can't tell you how many patients I've inherited from other providers that were already on oral clonazepam as the treatment. And we have to have a discussion about, is this the best rescue medication versus others? And what I like to tell families, I present them with the options, right? We're pediatricians, we do shared decision making, that's what we do. And so I just tell people about what the alternatives are and how they're easier to give. I've had families tell me, I put the tablet in the child's mouth and then it fell right out of his mouth. And so, you know, it's not always gonna be the best solution for families, but sometimes it is. Sometimes it is a medication that, you know, when I offer other choices, families say, you know what, I really want to stick with the one that costs $5. And it's hard to argue with that. So, so there is something to be said about the cost effectiveness of it. However, it is, there are still issues that you can encounter with this medication. The other thing that can be really useful for is a period of time, so what we call a bridge. So if somebody has febrile seizures, catamenial seizures, it's actually really useful as a temporary treatment because that half-life is very, very long. This is a nice schematic showing how you can dose clonazepam. I usually just dose based off of weight, but if you want something very simple for ease of dosing, you can look at this graphic. This table comes from a former colleague of mine, Dr. Fedak, who really summarized the information very nicely, that you have 3 different options that are FDA approved. You can see that the ages of approval are different, the half-life is very different, and the routes of administration are different. this is why there is no one size fits all to this, right? Every patient's going to be a little bit different based on their age, based on the type of seizures they have, based on the patient preferences and insurance needs. So we have some families that have no insurance, and sometimes you need to give them the cheapest option possible. And so a $5 option may beat a $400 option. I will note that our pharmaceutical partners do have assistance programs available. So it's not usually that's what they're actually paying, but it is hard when sometimes, I usually tell families, if you go to the pharmacy and they tell you it's $500, don't pay that. Call our clinic back and we can talk about ways that we can help. But I have had families unfortunately get stuck with the large bill there. The last thing I want to talk about is seizure action plan. So rescue medication is only as good as the seizure action plan that it's a part of. All of our patients should have seizure action plans, especially in the state of Texas, because in 2024, they are mandating a standardized seizure action plan throughout the state of Texas. This is a controversial subject because when they first introduced the seizure action plan, it was 7 pages long. So the Texas Education Agency was really unprepared, I think, for the amount of advocacy that the Epilepsy Foundation was ready to do, as well as all of our epilepsy centers here in Texas. So we pushed back and were able to negotiate down to a simple 1-page document like the Epilepsy Foundation. It's 1 page front and back, to be clear. It includes seizure types, triggers, first aid info, daily meds, and a rescue plan. We also have SAM's law in Texas, which is that all public school personnel with student contact need to be trained in seizure first aid. Unfortunately, that still doesn't quite happen, especially in rural settings. Not all schools have school nurses. Sometimes it's 1 school nurse for a school of 2,000 kids. So it's important that we still continue to advocate for those measures so that our kids are safe, because they spend 1/3 of their time at school, right? So they need not just a seizure action plan, they need a rescue med available at school, and they need personnel trained to handle that stuff. Seizure action plans, unfortunately, the idea came out of asthma action plans that we're probably all familiar with. So asthma action plans were very successful at reducing healthcare utilization. Seizure action plans, less so. There's mixed results on how much they actually benefit our patients in terms of a healthcare utilization standpoint. We do know they benefit caregivers. They benefit patients in terms of their anxiety level, and they also benefit schools in terms of being more involved with their patients and being aware of seizures. So for lots of reasons, I think we need seizure action plans and we need rescue medications for the vast majority of our patients. I'm not a very prescriptive person in general, so I won't say that we need rescue medicines for every single patient with epilepsy. There are some exceptions, infantile spasms, childhood absence epilepsy, for example. Some people may decide not to give a rescue med, but there are also lots of people that would give a rescue medication for that. And so it just kind of depends on your style practice, but there are lots of good options available, which is something that we couldn't have said 5 years ago, 10 years ago. And so I think we're in a really nice place to help save save our kids from missing school, save our kids from going to the ER, and hopefully minimizing the number of injuries and stuff that could happen from a prolonged seizure. Thank you.